that will be on the validity of maternal recall of birth weight and gestational age. The presentation will be given by Joanne Katz. Joanne is a professor and associate chair of the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Her research aims to reduce mortality and morbidity in underserved populations both in the U.S. and in low-income countries. And her areas of focus have included maternal, neonatal, and child health, nutritional diseases, infectious diseases, eye diseases, and blindness prevention. So here you go. Joanne, thank you.
Can't see. I'm going to look up ahead at everybody. Good morning, and thank you for the opportunity to present this work. I'm doing so on behalf of our Johns Hopkins team in Nepal, who did an amazing job at getting these data. Let's see. This is not working. Oh, there we go. Yeah, great. Thank you. So we were interested in measuring whether women could report low birth weight or preterm birth in their infants. And we used questions that DHS uses and also some additional questions that we were just trying out to see if they would work, particularly around preterm birth. So the rationale for looking at these particular indicators, they're not actually coverage indicators, but they are measures of the population in need of certain interventions. So in that sense, it works well within the context of improving coverage measures. There are about 20 million low birth weight babies born yearly around the world and about 15 million preterm babies. And low birth weight and preterm infants have a very high mortality. And another rationale for looking at particularly low birth weight is that the World Health Assembly has focused in on low birth weight as a measure for tracking progress of many countries. So this work was done in Nepal. Nepal's an interesting country. It has 3 ecologic zones. Everybody knows about the Himalayas, and then it has a sort of a hill region in the center. And our study was done in the low-lying Terai region of Nepal in Sarlahi district, which is right along the Indian border with the state of Bihar. So it's very similar in environment to North India. We were able to leverage a parent study, which was a community randomized trial to assess the impact of newborn oil massage with either sunflower seed or mustard seed oil that was looking at newborn morbidity and mortality. The way in which this parent study was done is we did surveillance for pregnancies by visiting women of childbearing age every 5 weeks at their home. We asked about date of last menstrual period. If it was within the last 5 weeks, we recorded that date. If they had not had a period in the past 5 weeks, we did a pregnancy test. If they were pregnant, we enrolled them in the study. And then we followed the pregnancy through 28 days postpartum. And when infants were born, we weighed them as soon as possible after birth at their homes using a digital scale that was precise to 10 grams. And then the way in which we leveraged this to take a look at recall was to then select some women from that parent trial for one additional household visit that was staggered at follow-up times between 1 and 24 months after birth. And then we asked them to recall the birth weight of the infant. We asked them about birth size and also length of gestation. So the questions that we asked, so the sort of gold standard was what we measured in the parent trial, and then these were the questions that we asked with a recall period that was varied over time. The first question was, how much did your child weigh at birth? And then secondly, when your child was born, was he or she very small, smaller than average, average, larger than average, or very large? And then we also asked if they had a birth record or birth certificate with the child's weight recorded on it. And if they did, we asked to see that, and then we wrote down the weight that was on that card. I should mention, and I'll say this again later, that only about 10% of women could present anything, any documentation about birth. And then we added a question which is not asked in DHS or MIX that says, when your child was born, was he or she born very early, early, on time, late, or very late? And this was an attempt to get some measure of preterm birth and to see if that might be a helpful question. So the analysis that we did was, our gold standard was what we measured in the parent trial, and a birth weight of less than 2,500 grams was low birth weight. We only selected measures of birth weight that were done within 72 hours of birth. And then for the maternal report, we asked whatever the weight was that they gave us, and then that would be whatever was under 2,500 grams was considered low birth weight by maternal report. And then for birth size, we grouped together the two categories, very small or smaller than average, and used that as a measure of low birth weight, and compared that to the gold standard of being under 2,500 grams. For preterm birth, we used as the gold standard our measure of gestational age being less than 37 complete weeks, and we used the date of last menstrual period, which had a recall of no more than 5 weeks, and on average about 2.5 weeks. So, and actually there's some work done in Bangladesh that compared this method of 5-weekly surveillance with ultrasound and actually showed quite good agreement. So I think we feel reasonably comfortable about that measure. And then for preterm, we used the categories mothers reported a very early or early birth in terms of timing of birth. And just to give you a little flavor for this population, we had a little bit more than half of the children born were males, and about half were facility deliveries, about half were home deliveries, very typical for this particular part of Nepal. And the average age, maternal age, was about 25, and 68% of these women had reported no schooling. So here is our measures of our gold standard of measured birth weight, which you see in the top left corner. And the average is around 2,700 grams. And then what you see below that is the maternal report of birth weight. And so the first thing to note is that you have this sort of heaping going on at like 100-gram intervals in particular. And then on the right-hand side, you can see the box plots of the two distributions, the gold standard in blue and the reported in pink. And what you can see is that on average, women were over-reporting the birth weight in terms of grams or kilograms, and there's more of a spread of the birth weight than there is in the actual measured birth weight. And then here's just the distribution of gestational age as we measured it from date of last menstrual period. The mode is around 40 weeks, which is what you would expect. And these were all live births, so there's a sort of limit, a lower limit to the gestational age here, which makes some sense, around 30 weeks or so. I'm so happy that Melinda gave the description of the way in which we measure the validity. So here are the 3 indicators that we were looking at. So low birth weight using a reported birth weight. The first thing you'll see is the sensitivity is quite poor at 45%. The specificity is quite good. The area under the curve is a little under 0.7, our sort of cut point for good validity. The The true prevalence of low birth weight in this population was 27%, and the estimated survey-based prevalence would have been 17%. So we're very much underestimating low birth weight if you're just using the DHS question. And this is because women were overestimating the birth weight when they reported it. And then similarly, if you use the birth size, that sort of very small, average, etc. If you use the categories very small or small at birth, again, the sensitivity was even worse. Specificity was still high. The true prevalence, again, was 27%, but the estimated survey prevalence would have been 7% if you just use those size categories. So very much, again, underestimating low birth weight. And then for preterm, those categories, again, poor sensitivity, good specificity. True prevalence of preterm in this population was 16%, which is what we found in many other studies. And the estimated prevalence would have been 5.7%. So again, a gross underestimation of the true preterm birth in this population. Because we had sort of designed the study to have varying recall periods between 1 and 24 months, we took a look at the validity of these measures by recall time period. And what you see is there's just a fairly uniformly high specificity and then relatively poor sensitivity, that there's no sort of real pattern of recall here. So what you get at 1 month is not very different than what you get at a 24-month recall. So in summary of these results, I wanted to again sort of just emphasize that this is a setting where so in the parent trial, we actually gave women a card that had the birth weight that we recorded on it, and, sort of like the equivalent of a birth certificate for them as part of the trial. And very few people had saved those cards or had them available. So it's the kind of setting where I feel like women, this was not a particularly important characteristic that women were thinking they needed to remember. They generally overestimated birth weight and birth size. So that led to high specificity but poor sensitivity for all of these three indicators. So low individual level accuracy, and at the population level, it was underestimating both low birth weight and preterm births. And then the length of recall did not seem to affect the accuracy of the indicators. We also did look at a variety of characteristics of women to see if there were particular characteristics that might improve have better recall or better validity. And we looked at socioeconomic status, maternal age, parity, sex of the infant, education, and none of those were predictors of accuracy of the recall. So I think this really does need to be looked at in other populations and communities. It might be very different in different places depending on women's interest in birth weight and measurement of birth weight rather than, so this was a particular kind of environment. So I would love to see this repeated in other countries first. But, maybe there are other ways in which one could refine these measures or improve them. We did a small study where we looked at, we did some more qualitative work, and we showed women photographs of very preterm or very small babies and contrasted those to see if photographs might be helpful. It was a small study, just qualitative, but I think those are some of the things that might be helpful to look at to improve accuracy. So I think I'll stop there, and thank you very much for your attention.
Any questions? Clarification questions? Yes?
Hi, Joanne.
Oh, hi. How are you?
I just had two questions, actually. The first was about whether women with the written birth weight, you said that was about 10%, and I was wondering if they had better recall. It sounds like you also had, I mean, you just mentioned the issue about how they didn't keep the cards that you gave them, but I was just wondering if there was a difference among those who had a written birth weight, whether they recalled, better than those who did not. And then
Oh, sorry, go ahead, yep.
Sorry, my second question was about the heaping. And so I was wondering if you measured what the women were told at the health facility. I think I know the answer to that, and I think it's no, but just wondering whether the heaping is happening by the health workers at the health facility or if it's the mothers who are doing their own kind of rounding up or rounding down.
Yeah, good. So I think the problem with looking at the ones who had birth weight cards is there were just so few. It was less than 10%. And so it's difficult to say much about that group, and there just wasn't that much data there. But we could certainly go back and look at it, but I think it would be too small a number to say much about that. In terms of the heaping, so only half of these were women who delivered at facilities. Oh, I should have mentioned that we actually did it also by who was delivering at a facility versus not, and there was no difference in the recall or accuracy there either. I think it's certainly possible that they were told something that was a roundup, but I don't know. We're actually, as part of the new grant, we're looking at antenatal care and validity of antenatal care, and that's something we could explore. What are people told? Because we'll be sitting in the clinics doing that, but that would be a good one to look at, I think, yeah.
Other questions?
I was just wondering about the preterm measure. If you had considered looking at sort of a calendar-based method, I know the DHS has some calendar modules that allow you to look at pregnancy by month, not breaking down by week, but if that was ever sort of looked at as a possible way to measure it.
Well, when we do these studies, we do use a calendar. But in this case, the way in which we did it, there was always no more than a 5-week recall because we were doing this sort of visiting every 5 weeks. So that we were able to sort of try to hone in on that time period because we knew what that period was specifically. Most people gave us a date. How accurate that was, I'm not sure. But the distribution, at least at a population level, looked reasonable. So, and as I said, a similar approach in a study in Bangladesh showed good accuracy with regard to ultrasound, which is also not a perfect gold standard either, but people take it as such, yeah.
Last question, yes?
I may have missed this in the presentation. When you were looking at sensitivity and specificity of low birth weight, I was curious whether you also looked at it by women who had large babies, or like whether there was any sort of differential based on the size of the baby that the mother had.
Great question, and we didn't do that, but we certainly can. We can, and one thing we did do is sort of a measurement of the average birth weight within each of those categories, and it definitely did go up with the categories going from very small to larger than average, but at an individual level, it wasn't very good. But on average, within those categories, it did sort of match the weight. But I think, thinking sort of down the road to gestational, diabetes and things like that, looking at the large end would also be of interest, I think, and what people might recall there. Great. Thank you. Thank you.